Thank you very much for your endurance. I'm going to be talking about Epicatechin, and I'm going to be talking about a very new therapeutic mechanism that's being introduced for the potential treatment of the muscular dystrophies. We are named after Cardero, the first Spanish painter who sent back the first Spanish painter in the New World who sent back images of North and South America, sending back basically information from the frontiers. And I can assure you that the biology I'm about to show you is coming from that same asteroid belt in outer space. I think we have some fragmentary but very provocative information. We're pushing ahead into an underserved population of Duchenne's. And I suspect, or I hope next year, actually I'll be in the group with the other companies. So think of this as an introduction to a new concept that is that we will be fleshing out over the next year or so in our trials. Now, this very familiar graph illustrates the Sarko-Glycan complex, mutations of which, of course, account for the variety of muscular dystrophies. And the mutations have also attracted initially the molecular interventions that were specific for those mutations. But one of the things that I'd like to remind you is that symptoms can be due to either the primary defect or secondary effects. In the primary defect, of course, you've got a changed gene. It's stable. In this case, it's based on the muscle, and the therapy is focused on the muscle, and it's, of course, confined to the genetic disorder being addressed by the molecular biological intervention. However, dystrophin is so fundamental to cell physiology of the muscle that there are a variety of secondary effects. And those secondary effects associated with adverse cell biology really actually account for most of the progressive nature of the symptoms that you are all wrestling with. The defect hasn't changed from a 7-year-old walking boy to a 10-year-old non-walking boy. What's changed is the milieu in which that defect is functioning and causing an adverse ripple effect. And these secondary effects are systemic. So, for example, heart failure has effects throughout the body, not just confined to the heart. And the therapeutic interventions are not gene-restricted. They're potentially applicable across the entire spectrum. And the therapy, therefore, is generalized and does not necessarily require focused delivery to the muscle. And we've seen many examples of interesting initiatives in the phosphodiesterase inhibitors, anti-inflammatories, and I'm going to introduce to you the next new concept, I think, and that's called mitochondrial biogenesis, which is the formation of new mitochondrial proteins and new mitochondria. And the mitochondria, for those of you who have forgotten your high school biology, are those little orange things, that's not their color in real life, that you see floating in the cytosol of the cell next to the nucleus. And instead of 3, a muscle cell can have between 5 and 10,000 of these, depending upon the type of muscle, obviously with the heart having the highest mitochondrial density in the body. Mitochondria make all the ATP. This fuels all of the cellular activities, and they wear out. They actually need to be replaced every week to 2 weeks, and that's called mitochondrial biogenesis. When you are unable to maintain new mitochondrial formation, you become depleted of your mitochondrial density, and the loss of mitochondria is associated with 2 prominent features. One is, of course, the loss of cell function. Cell function requires ATP. But the second thing that happens is that organs that are associated with mitochondrial depletion fail as tissue. And in fact, in a setting of mitochondrial loss, those organs are replaced by fibrosis, which is a glycolytic or mitochondrial independent form of tissue. So that mitochondria are quite critical to the process by which an organ surrenders to scar tissue and becomes unable to function. And this is what healthy muscle cells looks like, filled with mitochondria, which are the green stain, the blue are the nuclei. And when those mitochondria disappear, the cell becomes undifferentiated and quite ratty looking in tissue culture. Now, this is a slide courtesy of Tom Meyer, who is working with a compound that is presented earlier today that is protective against oxidative injury to mitochondria. And as he pointed out in his slide, loss of dystrophin is associated with an accumulation of calcium. That calcium is associated with the production of reactive oxygen species, oxygen radicals, and inflammation. That causes what he's correctly labels as mitochondrial dysfunction, and that eventuates in cell death and muscle degeneration. What I'm going to be talking about is actually a critical part of the spectrum of muscular dystrophy where you've lost your mitochondria. There's no mitochondria or fewer mitochondria left to protect. So we're talking about now, can you replace those mitochondria and roll back the ravages of time and bring that tissue back to a healthier function. And very preliminary data suggest that that is indeed possible. Now, obviously there's a gene defect, and we're not addressing that gene defect. But that gene defect results in the secondary damage to mitochondria, and it's the depletion of mitochondria that actually correlate with the progression of the disease, from the sarcopenia and loss of skeletal muscle strength to the eventual failure of the heart. This has been associated with both the calcium accumulation and the reactive oxygen species that are being generated, as well as the excessive metabolic demands of the hypercontractile muscle. The muscle is working in overtime to compensate for its weakness, and this produces an exhausting, sustained demand on the mitochondria, which literally burn themselves out because they generate oxygen radicals as they are trying to make more ATP to meet the demands of the muscle. And then this is associated with the triad of sarcopenia, heart failure, and respiratory failure, which are familiar to the families and physicians here. For reasons which we're going to speculate on in a few minutes, the ability to replace your mitochondria is not sufficient to compensate in Duchenne's. Now, interestingly enough, here in the year 2015, until very recently, nobody knew what the mechanism was for stimulating mitochondrial replacement. We did know that exercise causes muscle conditioning, and muscle conditioning is dependent on mitochondrial biogenesis. How that was mediated was completely unknown. And we have found that a molecule called Epicatechin, for reasons which I'll enunciate shortly, actually stimulates mitochondrial biogenesis, and thus we think is a candidate molecule for slowing or reversing the progression of myopathy. The loss of mitochondria in muscular dystrophy was identified more than 15 years ago. It's nearly as old as the discovery of dystrophin. And about 10 years ago, it was clear that in patients that had diabetic myopathy versus muscular dystrophy, that if you exercise them, the diabetics gained mitochondria density, and patients with muscular dystrophy lost. So they're not responding to the only known mechanism for inducing new mitochondrial formation. What our company, which is the smallest and newest that you've seen parade in front of you in the last 2 days, discovered is actually the hormone that is released during exercise that mediates new mitochondrial formation. This is a completely new hormonal pathway. Unfortunately, we're about to submit our manuscript, and so I can't talk about the identification of that right now, but I can tell you that this has when we discovered this hormone, there's not actually a single reference to it in PubMed. This is completely a new insight into how muscles work. And the mitochondria are the source of the hormone. So it's an autocrine effect, whereas where stimulated mitochondria release a hormone that feeds back on mitochondria nucleus, stimulates the formation of new mitochondria. And we're going to propose over the next few years that one may think of Duchenne's muscular dystrophy with its loss of mitochondria in the heart and muscle as actually a form of hormone deficiency, one that requires replacement therapy. We did computational chemical modeling on this hormone and actually discovered a compound that occurs in nature called Epicatechin, which was functioning in structural homology to this hormone. That is, it's a mimic of this hormone. No other phenol has this property. It's unique to this. In fact, even the stereoisomer of this molecule has no biology. So this is very, very specific to this one compound. And the rare plus isoform, which is found only in a berry in South America, actually is very closely resembles the native human hormone that's being produced in exercise. And this is the version of Epicatechin, together with its more potent chemical derivatives that we have made, that we're going to be advancing into the clinic for Duchenne's muscular dystrophy. So you don't need to be an electron microscopist to see the effect of Epicatechin on human skeletal muscle. In the top left, you see primary cultures of muscle that have been placed in culture long enough under hypoxic conditions so that the mitochondria have been largely depleted. This is not, although this is from a normal individual in the top left, this is a chronically ischemic tissue culture preparation. And 48 hours after adding Epicatechin, you see all those little structures that look like worms are new mitochondria. It's a completely unsubtle and very profound effect on muscle cells. In addition, if you look at the enlargement of the mitochondria on the left, you see those little stripes. Those stripes are called cristae, and those stripes are actually where ATP is being made. And for the first time that we know of in scientific history, we have an oral compound that also increases the cristae density by 50%. So that means that a muscle cell exposed to Epicatechin is not only making more ATP per cell, it's actually making more ATP per single mitochondrion. And this is a very unusual property of this compound. I'm not going to get into the pathways that are triggered from the receptor for Epicatechin, but I do want to point out that the process by which hypercontractility and calcium accumulation leads to mitochondrial depletion, muscle atrophy, and metabolic disorders on the left. Pathways that are activated by Epicatechin and the human hormone are actually seem to be specifically designed to counter that effect. That is, increased catalase and SOD2, which are the endogenous antioxidants of the mitochondria, go up. So, in fact, they chew up the reactive oxygen species. PGC1 alpha and NO are both activated by Epicatechin, which are cofactors for the stimulation of new mitochondrial formation. PGC1 alpha also stimulates muscle regeneration. Weird fact number 2. This is the only small molecule compound ever discovered to stimulate follistatin and to lower myostatin in both muscle and the plasma. Now, you've all seen discussions about neutralizing myostatin with aptamers or antibodies or providing follistatin in recombinant form. This is an oral compound that does exactly that, and I'll show you some of that data in a minute. And through the activation of AMPK and the breakdown of fat, Epicatechin, as we've shown in models of metabolic, not models, in the human cases of diabetes and metabolic syndrome, has a profound effect on restoring insulin sensitivity and lowering triglycerides. So the whole sequence or progression of muscular dystrophy as a clinical syndrome actually has a specific counterpoint in the effects mediated by epicatechin. So we did a small pilot study with Craig McDonald looking at Becker's muscular dystrophy and at UC Davis. And this was just 7 adults. And the unusual aspect, one of the unusual aspects of this trial compared to some of the trials that you've been seeing is that it was 8 weeks of an oral therapy, 100 milligrams a day. And we chose 8 weeks because that was all that we had the money to make. So we had no more compound. We have a proprietary method for synthesizing pharmaceutical-grade epicatechin. That's what we had. That's what we went with. A very short time frame in the context of the trials that you're accustomed to seeing. And Dr. McDonald and his team did muscle biopsies and looked at various secondary endpoints, and I'm going to just show you a selection of some of that data. And what we basically found at the beginning, at the end of the 8 weeks, where each patient served as his own control, was that epicatechin had strikingly positive effects on mitochondrial and skeletal muscle biomarkers for both structure and function. We saw upregulation of enzymes that regulate mitochondrial proliferation. That's the signaling. We saw evidence for mitochondrial biogenesis in terms of number of mitochondria or cristae formation or both. We saw evidence of both primary biomarkers of muscle regeneration as well as factors that drive muscle regeneration like follistatin. And very strikingly, we saw very strong stimulation of numerous sarcoglycans. Epicatechin in these patients increased dystrophin, eutrophin, and dysferlin. And we've seen not just this, but we've seen this in acquired examples of sarcoglycan deficiency, not genetic. In diabetes, many people don't know that in diabetic myopathy, a lot of sarcoglycans are depleted. We can restore them back to normal density in diabetics with muscle disease. So there's a strong sarcoglycan structural effect on the stimulation seen with epicatechin. On the left, you'll see a patient at the start of the trial, and outlined in yellow in the bottom left corner, you'll see the mitochondria, which are difficult to see otherwise without that yellow ring. And after 8 weeks, in this particular patient, you can see that there was a doubling of the mitochondrial number as well as a doubling of the mitochondrial volume to the muscle volume. That is, these patients had more of their muscle filled with mitochondria as a component of the muscle. And it was a very striking effect. And this was associated with some very striking metabolic effects on muscle function, together with the suggestion of what would eventually, we believe, will result in muscle regeneration when we treat for longer periods of time. So you can see in the top left corner that these patients actually within 2 weeks, that's what time 1 is, started showing, many of them, an increase in follistatin in the blood. And you can see that over at time point 2, which is 4 weeks, and at time point 3, which is 12 weeks, that they all go up. Some of them go up later than others. And if you look in the top right-hand corner are the follistatin levels with a p-value to 4 figures, which I've never seen in a small human clinical trial, that there is a universal increase in follistatin in the blood, and we know that it was also increased in the muscle biopsies. You can see the myosin in the plasma going down, and we also see an even more precipitous decrease in myosin in the muscle that was biopsied. So that it was and then because follistatin is actually an endogenous inhibitor of myostatin, we created what we think is a potentially new biomarker for Duchenne responsiveness, which is the ratio of follistatin to myostatin, because the more follistatin you have, even if your myostatin plasma levels are hold steady, it's inhibited functionally by the presence of follistatin. So when you look at that ratio, you see 3 to 4-fold changes over an 8-week period in the follistatin to myostatin ratio. And we're actually going to be exploring this as a potential new biomarker for looking at early evidence of efficacy when we apply this to Duchenne's, because it's happening in a couple of weeks. Now, when we looked at the effect on muscle metabolism in these patients who are in basically their 20s and 30s and early 40s, you can see that in the left-hand side, you can see in a graded work exercise, so these patients were responding to work of increasing loads, and you can see that they all had elevated lactate levels, which then skyrocketed as you went out to the right for a bigger workload. And across the board, they were generating less lactate in response to the workload than they were 8 weeks earlier. On the right-hand side, you see the oxygen per kilogram by workload. That's the efficiency of the mitochondria. And you can see again, especially as you get up to the higher workloads, that all the patients were able to more efficiently utilize the oxygen that were being given. And that also, of course, is reflected in the lactate levels, because when mitochondria aren't working very well, lactate levels go up. So here is an example of a total body metabolic effect where we're looking at oxygen consumption by both skeletal muscle and, effectively, of course, the heart. I think this was the thing that we were somewhat unprepared for. This is a heart rate over the graded work, and you can see that these patients have a resting tachycardia, which is typical for the muscular dystrophies. And as they increase their workload, the tachycardia heart rate goes way up. Why is that? Well, I'm going to show you a 150-year-old equation. You don't have to know any molecular biology for this. But the cardiac output, which these patients have to increase to handle the workload, is a function of heart rate times stroke volume. And as many of you know, the heart failure is a dilation heart failure, dilated myopathy, where the ventricle does not contract. The stroke volume does not fluctuate very easily. So if the stroke volume is fixed because you're in heart failure, the only way you can increase your cardiac output is by increasing your heart rate. As we got up into the upper ranges or as these patients got up into the upper ranges of the demands being placed on them, their heart rate stayed down. The only way this can happen physiologically is to increase your stroke volume. This never happens in cardiomyopathy. So in 8 weeks, these patients showed an ability to contract their hearts better. Now, we weren't prepared for this, so we don't have echocardiograms, unfortunately, but we did see an indirect evidence for the effect of epicatechin on heart function by looking at the BNP levels of these individuals. Now, BNP doesn't always track with heart failure in Duchenne's, certainly, or in Becker's, because you can have heart failure and have, for mysterious reasons, normal levels of BNP. But what I want to point out to you is that whatever level your BNP is, that if in a 8-week setting it's going down, you are decreasing strain on the left ventricle. That is, you are improving the ability of the ventricle to contract and lower left ventricular and diastolic pressures. And what... Oh, I'm sorry. And so anyway, these patients basically went up to a 75% decrease in their plasma BNP levels, indicating the suggestion of a relatively rapid response to heart dysfunction. What we saw were functional improvements reported by the patients in terms of not needing a cane anymore. They can stoop to pick up items off the floor. They can stay on their feet through the day. They showed improvements in stair climb and the 10-minute run-walk test. Most of them showed an improvement in the 6-minute walk in 2 months. And then on the cardiovascular endpoints, in addition to what I just summarized, they all showed improvement in blood oxygen levels, oxygen saturation, suggesting both improved peripheral blood flow, which we measured, as well as improved cardiac function. So when I sat down with Craig to discuss what we do next, and we were reviewing the data with Pat Furlong and John Porter, and I said, we'll do the 7 to 10-year-old early stage study and confirm this in Duchenne's with following the path that's already been blazed by the pioneering companies before us. And Craig McDonald sat down and explained to me in a very scholarly way that with what he was seeing, it was time to actually do something for older patients with Duchenne's who have disorders that might be extremely responsive to our intervention. Pat had a very different approach to persuading me. She threw me to the ground and sat on my back and would not let me off the ground until I had consented to go into still uncharted territory. John Porter had just come into the organization. When I called weekly for help, he came over and stood on my head. So it was a very persuasive argument. But in fact, as this meeting illustrated, when you look at these are the companies that were here the last couple of days, and you look at where they're aiming along the spectrum of muscular dystrophy, there's very little out at the point when you're past 15 years old. And that actually, since we're dealing with a pioneering mechanism, maybe it makes sense for us to also pioneer in terms of a clinical development strategy for dealing with late-stage Duchenne's. So we are going to be looking at non-ambulatory patients. We are going to be looking at either preservation or improvement of arm strength and range of motion. We're going to be looking at effects on pulmonary function, and we're going to be determining if we can reverse established heart failure. There's very limited data on heart failure in Duchenne's patients, a little bit small studies that suggest if you start therapy early, you may delay onset of heart failure. There's nothing to indicate the potential for reversal of established cardiac dysfunction. We have 2 trials that are being planned, one in the early stage of non-ambulatory Duchenne's, where the heart failure is preclinical and the biggest worry is maintaining strength in the arms and range of motion. And then we're going to look at the late stage where the heart failure is now dominant, and these young adults have lost much of their arm strength, and we're going to be focusing on the clinical and cardiac and respiratory disorders, as well as determining whether or not we can reverse any of the upper extremity defects. So in summary, we actually are introducing a novel class of therapeutics, which are inducers of mitochondrial biogenesis. I think we've been really inspired by PPMD and the physicians and families and parents that stand behind PPMD to actually make this our first a clinical effort. We are committed, if we see something, to drive this right through to registration as fast as we can, because this is obviously an extremely underserved population, and we feel that we can have a potentially positive effect on this. We know that we can restore mitochondrial density. We can prevent organ fibrosis in animals and actually reverse already established fibrosis in the heart and muscle. We've seen improved muscle structure and function in animals and humans. We've seen an improvement in cardiac function. This should not be restricted by the gene defect that is contributing to the clinical progression. And we think that this is very interesting as a candidate for combination therapy, which PPMD is beginning to lead the charge on, because we should, with the sarcoglycan effect, for example, be able to amplify a molecular intervention to induce expression of dystrophin, as well as we know that we can stimulate NO and restore mitochondrial density. So we think that in a single compound, we may well be able to synergize with things that are already being developed but are not perhaps fully effective and could use some bounce in order to get the patients across the finish line safely. So we think that this is going to be a very interesting avenue for us to explore in the future. Thank you for your patience with my running over, and we have time for a few questions.
This on? Yeah, so let's just take just a couple questions if anybody has anything. Microphone, I see one there, one there.
Okay, well, next year, you're going to have a lot of questions, I can assure you.
Hi, I know your first study was with Becker's, and we're well acquainted with Dr. McDonald and his group, and I wanted to know if they're going to be starting another Becker's trial.
Yes, actually, Dr. McDonald is quite an advocate for this, so we have an extension study, because we understand 8 weeks is too short a time. So we're going to be extending the effects of minus epicatechin for several months to allow for muscle, what we believe will be muscle regeneration, which is what we've seen in the animals, and then animal models. And then we're going to convert the Becker's patients over to the plus form, which is about 10 times more potent. The Becker's patient was done with the minus isoform, which is less active. So yes, we're going to be continuing Becker work in parallel. We're not going to leave them behind. We started there because they can sign informed consent, and we had never put this into a genetic disease before, so it was important for us to have to be able to make sure of safety and efficacy before we contemplated going into Duchenne's.
Will that open up to new Becker patients?
I'm going to let Dr. McDonald be the arbiter of that.
Okay. I will contact him immediately.
Okay.
First of all, thank you for your work and what you're doing for the Duchenne boys. I'm a little uncertain, as I thought epicatechin was naturally occurring in like chocolates and some other type of natural supplies. And if it's a refinement process, wouldn't that be more of a supplement than a drug? And wouldn't that change the approval process?
Well, it actually may change the approval process, but the problem with the extracts, or it is found in things like chocolate in very small amounts. The problem is that very closely related compounds are also found in chocolate that are highly inhibitory to this process. And by the way, all those other compounds are antioxidants. And the data is very clear now in the healthy population that antioxidants prevent mitochondrial biogenesis in response to exercise conditioning. So please do not infer from this that you can go out and take dark chocolate or give this to your kids and you're going to see an effect. We have to purify this and have it absolutely free of any of the contaminating phenols that are inhibitory. But it is unusually safe. So the attractive thing to me about developing this before we get into the more potent derivatives is there's no adverse events have ever been described for this compound. There's over 400 papers on the minus isoform. The plus is 10 times more potent. We're going to go with that, but it seems to be equally safe. And so we are hoping that that's going to allow us to go on to an accelerated development program. And PPMD has actually offered to work very closely with us to make that case to the FDA. The second generation compounds are what are called NCEs. They're not found in nature, and we're going to have to go through a more formal toxin pharmacology program, and they are more potent. But this is plenty active, and so we think that we are hoping that that will give us some allowance in terms of getting this into the market quickly.
Thank you.
Okay, George. Thanks.
Okay.
Okay, we're going to move straight into a panel discussion. If I c- I'm sorry? Oh, I didn't even see. You know, there are spotlights right on the stage, and actually what you can see here is very limited. So, sure.
Hi, as a Duchenne's patient myself, this is all very promising, and I hope to see more studies like this in the future. Also, as a patient who is currently taking therapeutics for targeting the gene itself to help reverse, well, not help reverse, but help with stimulation of functional dystrophin. My question is more along the lines of, for patients that are with mutations where there aren't any drug targets currently, or there aren't any drug targets that are currently within a phase 2 trial, or where they're not taking any drug targets, would epicatechin be if they were to take a compound such as Epicatechin, where dystrophin is still functionally inert and they have none at all, and there's still mitochondrial biogenesis, is there, I guess what I'm asking, is there kind of an offset to secondary symptoms as a result of a lack of dystrophin, given that the Epicatechin study here was on Becker's patients who already are producing dystrophin, just not enough of it to begin with?
Excellent question. And obviously, if no one is on, if someone has a gene defect that for which they are not on a gene-based intervention, Epicatechin is not going to bring back a protein for which there's no functioning gene.
Right.
But I think we would all agree that if we could roll back the clock, the gene defect doesn't change between the ages of 7 and 15. Your body changes.
Right.
The body of the patient changes in response to the defect. We have suggestive evidence, and we're going to be testing the hypothesis that we can reverse the march of time, or perhaps stop it if we can't reverse it, so that we can affect progression, which is a function of the secondary effects, not the primary defect by itself. Mm-hmm. Obviously, when patients are 5 and 6 years old, they're much more functional than when they're 15 to 20. So yes, I believe the reason we're doing this is that and the reason we're going to be looking at patients who are on no gene-specific or targeted therapy is that we believe that the symptoms may well be very responsive, even though there is no more expression of dystrophin. And remember, what we have seen, and not just in the Becker's patients, but in the diabetes patients, we have seen major increases in eutrophin expression. So you saw earlier today a discussion of stimulation of eutrophin expression. So we do think that even with a gene defect, we may well see an amplified expression of a compensatory protein.
Right. Thank you.
Okay.
Thanks, George.